Hello, 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 hello. Doctors, please let me know. Can you hear my voice? Can you hear my voice? Let me know. If you can hear my voice, then we can proceed, okay? Always exciting to come your way. Always exciting to, hear your voice. So please let me know. If you can hear my voice, then we can roll. Please let me know. Let me know. Okay, this is Dr. Brony, your friend, your brother in this whole journey. So please let me know. If you can hear my voice, then we can take it from there. I'm just trying to make sure that we have everything set up properly. So let me just do my best to share my screen. So yeah, I'm just trying. Please, can you hear my voice? Okay, good. Let me see. Share screen. Let's see. I think screen. I'm just checking. Look, I'm just trying to okay, let me see. Okay, so I think you can you see the screen as well? As I roll the screen, please, can you see that one as well? Can you see it? Okay, good. I think we're good to go. We're good to go. So please, make sure you send the link to as many friends as possible in your WhatsApp groups, in your Discord groups, in your Telegram groups. Share it on your profile, share it on your your WhatsApp status. Tell your friends to join us. Okay, it's always a pleasure. And today we have a lot to cover. We're going to cover some questions, and then what we'll also do is to do active recall. In fact, this is something I'm introducing into our training. The reason is because a lot of people learn passively, and it's not really helping, with getting the concepts right. So what I'm doing is, after we try some MCQs with learning points, we get into active recall, where I will actually pose a question and you need to give me the answer, because that helps me to know that you are doing very well. Okay, so we're getting into it. MCC objective for today is allergic reactions and atopy, and we're going to use a question-based approach. And remember that every time we have to deal with MCC Q1 objectives, we go with the rationale first, right? So it says allergic conditions are common and may be life-threatening, and that is why in the exam you need to know how to deal with this, because for all the MCQ1 objectives we've been reviewing, and if you are new to MedCognito and the way we do our things, all you need to do is to go to our YouTube channel and then go under live. Under live, you will see that all the videos we've done are there. Okay, so doctors, when you go to live, you'll see that all the videos are there. Now, you realize that the main word the medical council uses is common and life-threatening. Common, life-threatening. Common, life-threatening. So you want to make sure that you understand all the common medical conditions, all the life-threatening medical conditions, and an allergic reaction and atopy is one of them. Okay, so many patients may have multiple manifestations of an atopic disorder. Okay, now the causal conditions. Allergic reactions may be present with the following clinical manifestations. Anaphylaxis. Okay, so if you want to know the topics you need to learn under this, number one, learn about anaphylaxis, drug allergies, food allergies, insect stings, idiopathic. So you've got to learn, okay, what is the commonest drug class which causes anaphylaxis? What food options cause anaphylaxis commonly? What insects or which common insects lead to anaphylaxis? If there's an insect bite, how do you deal with it? Okay, so in one sentence, you realize that you have so many things to learn from. And then urticaria and angioedema. So that's another topic you need to learn. So after you've learned anaphylaxis, make sure you've mastered urticaria. Make sure you've mastered angioedema, drugs, food, physical stresses like cold and exercise, and even congenital causes. And then you've got to also master atopic dermatitis. So if you ask me, Dr. Brony, what are the high yield topics I need to learn? I'll say, look, just go to the objectives, go to the causal conditions, and then bam, right? And then respiratory allergy as well, like pollen, dust mites. Okay. Now, given a patient with an allergic reaction, the candidate will determine the cause and severity and will initiate an appropriate management plan. and particular attention should be paid to findings suggestive of anaphylaxis and its management. Doctors, so this is something I really, really want you to know. If you are learning this, there's one topic you don't want to miss: anaphylaxis and its management. So first line treatment, second line treatment. What do you do if a patient comes with anaphylaxis and bronchospasm? Do you need to do lab work, right? These are the things you need to master if you want to ace this particular topic in the MCQ1 exam. Okay, so the medical council is literally telling you how you should study. But you know, a lot of candidates, what we do is that, oh, we come in, someone tells us about, oh, this book, sure, all the various books which are suggested are good, right? But then when you're going through those books, make sure that you are learning the things which are stated in the objectives. So you can't tell me you've mastered anaphylaxis when you don't know how to manage anaphylaxis, like a patient who you've given your epinephrine and it's not working. What is your next best step? These are the things I want to start drawing your attention to. So given a patient with an allergic reaction, the candidate will list and interpret critical clinical findings, including history of drug ingestion, food ingestion, stings, environmental and occupational exposures, exercise, or family history. All right. And then results of an appropriate physical examination. So which foods cause anaphylaxis? Which drugs cause anaphylaxis? If a patient has anaphylaxis, what physical exam findings will you get? Okay, the same with angioedema, the same with atopic dermatitis. List and interpret critical investigations, including appropriate use of tests designed to identify allergens. So you also have to master allergy testing. So if you have your up-to-date or Toronto Note or whatever resource you are using, right? You need to learn allergy testing as well, and construct an effective management plan, including emergency management of anaphylaxis with appropriate measures, and long-term management, including patient education, counseling, reassignment or removal from work, avoiding triggers. So, Doc, you realize that this objective has quite a number of things you need to know. So, as usual, let's try some questions. Remember, this is only the first part of the class. Today, I told the people in the MedCognito program that we're going to do about 140 slides, okay? So please, kindly make sure that you have some water with you. Make sure that you have some orange juice so you don't become hypoglycemic, right? So I have my water here. This is my water, please. So please, if you don't have it, just tell me to wait. Get your son or your daughter or your husband or your wife to get you some water. And then make sure you also have some orange juice as well by your side so you don't become hypoglycemic. And especially for the MedCognito candidates, because after this class, remember you have a rapid review class as well in the evening. So make sure that you brace yourself for impact. So Dr. Jewel says, I have my coffee. She says she has her coffee with her. Okay, good. All right. So doctors, please. And as usual, my phone number is +1 306 891 5649. +1 306 891 5649. Just send me a picture of the coffee, the orange juice, your table where you are learning this from with us, so that we can all get it going. Okay, +1 306 891 5649. That's the number which is going at the bottom of the screen. Just send me so that we can really interact and follow up from there. So let's try some questions. So you have a 43-year-old hiker is attacked by a group of wasps and develops sudden wheezing and shortness of breath with tachycardia. What's the best initial treatment? We move. What's the best initial treatment? A, intravenous steroids with antihistamines. B, epinephrine intramuscularly and antihistamines. C, epinephrine intravascularly and antivenom. D, remove the stinger and give a non-steroidal anti-inflammatory agent. E, venom immunotherapy and discharge the patient with prescription of EpiPen. Let's go. Sure, Dr. Nuri, I'm waiting for your picture, please. I'm waiting for your picture. You're so excited. I'm waiting for your picture. And doctors, please, don't forget, if you're on our YouTube channel right now and you've not yet subscribed, man, you are losing a lot. You are losing a lot. So please, kindly just click on the like and the subscribe button right now. Okay, because of the help you've offered, we are growing the YouTube channel, and the more we get doctors to subscribe, the more the algorithm will also show the videos to other doctors. Okay, so please, currently we are at 2,336 subscribers. Help us with this stream to move it to 2,400 subscribers. Okay, let's go. So the correct answer, let's look at the correct answer. The correct answer is B. I see a lot of doctors going for B. So please, doctors, another thing, make sure that you are really interacting. If we ask a question, put in your answer. Okay, the correct answer is B. And why is it so? Anaphylaxis from wasp, and wasp is Hymenoptera, okay, sting, must be treated like any other cause of anaphylaxis. Now, IM epinephrine is the mainstay of treatment. IM epinephrine. You realize that H1 and H2 receptor blockers may be good adjuncts, but they should not delay delivery of epinephrine. Okay, so epinephrine, IM epinephrine, please remember, anaphylaxis, IM epinephrine. Steroids also help with delayed reaction, but does not treat anaphylaxis. So the learning point from this slide is that someone comes in with anaphylaxis. If I'm giving various options, I'm going to go with IM epinephrine. Go with IM epinephrine. Why do you give steroids? Steroids will help with delayed reactions, but steroids don't treat the acute anaphylaxis. That's the lesson you want to learn there. Okay. Now, beta agonists help with wheezing. So if the patient has wheezing, anaphylaxis, but it's not the first medication to give. So don't confuse it. Even though this patient is said to be wheezing, we know that this patient probably is not asthmatic. The reaction is because of the insect which stung the patient. Okay, and what is the indication for IV epinephrine? This one you also have to write it in your book right now. IV epinephrine is reserved for patients whose symptoms are refractory to initial treatment. So if you go into your board exam and you see IV epinephrine as one of the first things you need to do, no, you give your IM epinephrine first. You give, and at times you can even repeat it. It's only when the patient's symptoms have become refractory, in other words, the patient is not improving, that is when you give your IV epinephrine. Okay, and then discharge with EpiPen auto-injector is appropriate only when you've done your initial management. If your initial management is done, please don't discharge the patient and say go home and use an EpiPen. And do not forget to refer the patient to outpatient immunotherapy and desensitization. So that is it for the first question. And I'm very happy almost everyone got B correct. So an otherwise healthy 30-year-old woman comes to the clinic with a history of ongoing fits of coughing and trouble catching her breath with a whistling noise breathing. The vitals are blood pressure of 120/80, respiratory rate is 16 cycles per minute, SpO2 is 95% on room air. What is your next best step? So this one is looking at investigations to do spirometry, chest x-ray, arterial blood gas, which is ABG, metacholine challenge, and then chest CT scan. What is your correct answer? Let's go. Doctors, and I can see that some of you are hitting on the subscribe button. Also, don't forget to like us on Facebook or on YouTube, okay? And then we can get things going. Don't forget to like us on Facebook or YouTube. So what is going to be your answer? Is it going to be spirometry? Is it going to be a chest x-ray? Is it going to be arterial blood gas, metacholine challenge, or chest CT scan? What's the correct answer? Good. I see a lot of you going with A, spirometry. A, spirometry. And that is the correct answer. What is the teaching point here? Patient has symptoms of bronchospasm, and therefore spirometry will be essential. Okay, and if spirometry is normal because the presentation is mild, that is when you consider the metacholine challenge test. So first, patient has come in with anaphylaxis. Boom, give your IM epinephrine into the thigh. Give the IM epinephrine, right? Patient is wheezing. You've given, your Ventolin, and then the patient is still wheezing. You've given your second dose of Ventolin. Patient is still wheezing. You can even give your third dose of Ventolin. Don't forget that the first respiratory test you want to do will be spirometry. Chest radiograph is not indicated at this time because of the lack of constitutional symptoms. Okay, and obtaining an ABG may be helpful when a patient presents with respiratory distress, but certainly not in the office setting. Okay, so this patient has just some wheezing. It looks like if you look at the vitals, they are stable, so you're good to go. Do your spirometry. Now, next question. This is a very interesting one because I'll use this to teach all the types of hypersensitivity reactions we need to know in just one slide. So let's rock and roll. So you have a 35-year-old male who develops urticaria and angioedema within 30 minutes of taking a newly prescribed antibiotic. This reaction is best classified as A, type 1 hypersensitivity reaction, B, type 2 hypersensitivity reaction, C, type 3 hypersensitivity reaction, D, type 4 hypersensitivity reaction. In this case, I want you to be very careful. Like, you may get an answer right, but why is the answer? Why did you choose that particular answer? That is what I want you to know in terms of how early the presentation was and the way the patient presented. So is it A, is it B, is it C, or is it D? Is it A, B, C, or D? So I see some people going for A, some are even going for B, some have even jumped to D. Interesting, right? I thought everyone was going to get this right, but the correct answer is A. This is a type 1 hypersensitivity reaction. And let's take our time and use this to learn it very well. Type 1 hypersensitivity reaction, remember, is immediate. That's something, please write this in your book right away. Hypersensitivity reactions made ridiculously simple on just one slide. Number one, type 1 hypersensitivity reactions are immediate in onset. The second thing you also want to know is that what mediates type 1 hypersensitivity reaction? It is IgE mediated. And it is because there's activation of mast cells and basophils. Please write these down. Write these down. Type 1 hypersensitivity reaction. Immediate, IgE mediated, mast cells and basophils. Okay? Remember that this patient's symptoms just occurred in 30 minutes. Now, what is the difference in terms of duration with type 1 hypersensitivity, type 2, type 3, and type 4? You realize that type 1 is the one which is immediate. Type 2, type 3, and type 4 are all delayed. Please write down in your book. Delayed, 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 delayed. Type 1 is immediate. Type 2, type 3, type 4, delayed. Type 1 is IgE mediated. Type 2 is antibody mediated. Please write this down in your book. Antibody mediated and delayed. Type 1 is IgE mediated and immediate. Type 3 is immune complex deposition or immune complex mediated and is also delayed. So while type 1 is IgE mediated and immediate, type 2 is antibody mediated and delayed. Type 3 is immune complex deposition mediation and is also delayed. And type 4 is T cell mediated. Type 4 is T cell mediated and delayed in onset. Usually it occurs days to weeks after exposure. Okay. Doctors, does that make it clear? Which one is delayed? Which one is immediate? Type 1 is immediate. Which one is IgE mediated? Type 1. Which one is antibody mediated? Type 2. Which one is immune complex mediated? Type 3. Which one is T cell mediated? Type 4. Doctors, please let me know. Can I move on? Let's make these concepts ridiculously simple. Let's not complicate things. The MCQ one is at the level of a medical student. It is not an immunology exam. It is not an internal medicine Royal College exam. It is an exam at the level of a medical student. So can we move on? Beautiful, 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 beautiful. Type 1, IgE mediated, immediate. Type 2, antibody mediated, delayed. Type 3, immune complex mediated, delayed. Type 4, T cell mediated, delayed. Boom. You get this, you're good to go. Okay, beautiful. So doctors, let's move on to the next one. You have a patient who presents with severe rash and fever 2 weeks after starting an antibiotic. Laboratory findings include eosinophilia and elevated liver enzymes. What's the most likely diagnosis? Severe rash, fever, 2 weeks after starting an antibiotic, eosinophilia, elevated liver enzymes. What's the most related diagnosis? A, acute generalized exanthematous pustulosis. B, drug reaction with eosinophilia and systemic symptoms. C, Stevens-Johnson syndrome. D, serum sickness-like reaction. What's the correct answer? And doctors, I'll really appreciate it if you can click on our subscribe button on YouTube and then subscribe so that we can help grow the channel with you. Okay? Fever 2 weeks after taking an antibiotic rash. Okay? Eosinophilia and elevated liver enzymes. And the correct answer is a drug reaction with eosinophilia and systemic symptoms. This is DRESS syndrome. DRESS syndrome. Please write it down. DRESS syndrome. So this is one differential you need to learn about. DRESS syndrome. And what are the characteristics of DRESS syndrome? The patient will present with severe rash. The patient will present with fever. The patient will present with eosinophilia. There's an organ involvement. And usually note the duration your examiner will be quizzing you on. It will be between 2 to 6 weeks after starting the medication. DRESS syndrome. Drug reaction with eosinophilia and systemic symptoms. Let me say it again. Drug reaction with eosinophilia and systemic symptoms. DRESS syndrome. And the incorrect answer is generalized exanthematous pustulosis, which we call AGEP, usually presents with pustular eruption and fever, but not with eosinophilia. Okay, so that is how you separate DRESS syndrome from acute generalized exanthematous pustulosis. And then Stevens-Johnson, usually if a patient presents with Stevens-Johnson, you realize that you'll be told that there's mucosal involvement and extensive skin detachment. Okay, mucosal involvement and extensive skin detachment. And then when we get to serum sickness-like reaction, it is characterized by fever, rash, arthralgia, but not typically eosinophilia. So please, these three differentials, I need you to, if you want to take a screenshot, just do it. Make sure you've mastered the difference between DRESS syndrome, acute generalized exanthematous pustulosis, Stevens-Johnson syndrome, and serum sickness-like reaction. All right? Good. Now, you have a 5-year-old boy who presents with urticaria and angioedema that develop within minutes of eating peanuts, which are the following is the most likely mechanism behind his symptoms. A, IgE-mediated reaction. B, non-IgE-mediated reaction. C, food protein-induced enterocolitis syndrome. And D, celiac disease. This one is pretty straightforward. Let's just finish it. Boom, 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 and move on. 5-year-old presents with urticaria and angioedema that develop within minutes of eating peanuts. Which of the following is the most likely mechanism behind the symptom? A, B, C, or D? And the correct answer is A. We learned this already. IgE-mediated reactions usually occur quickly. They are mast cell. There's mast cell involvement, right? So that is it. Let's go to the next question. A 30-year-old man with a history of birch pollen allergy develops pruritus and mild swelling of the lips after eating fresh apples. Which condition does this most likely indicate? A, food protein-induced enterocolitis syndrome. B, oral allergy syndrome. C, IgE-mediated anaphylaxis. And D, non-IgE-mediated food allergy. A 30-year-old man with a history of birch pollen allergy develops pruritus and mild swelling of the lips after eating fresh apples. What's your correct answer? So this is what we call the oral allergy syndrome. That is B. 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 So it's what we also call pollen food allergy syndrome. Okay, it commonly occurs in patients with allergic rhinitis to pollen. All right, and the symptoms include pruritus and mild swelling of the lips when they eat fresh, uncooked fruits like apples. So this is also a diagnosis I want you to pay attention to. Okay, you have a patient who has allergic reaction or allergic rhinitis to pollen, and that patient develops swelling of the lips when they take fresh, uncooked fruits. The diagnosis you don't want to play with is oral allergy syndrome. The issue with the IgE mediated anaphylaxis, which some candidates went for C, is that usually it involves multiple systems that can include symptoms like urticaria, okay, angioedema, and hypotension, but they are not described here. So please learn about oral allergy syndrome, and you can use this information I've just provided here, and that should be fine. Oral allergy syndrome. The patient usually has allergic rhinitis to pollen. The patient may have symptoms which include pruritus, mild swelling of the lips upon ingestion of fresh, uncooked fruits, okay, like apples. So someone wants me to just show the question again. So Dr. I think that's Dr. Isma. Yeah. So that's the question, okay? So we'll just move on to the next question then. You have a 40-year-old woman who presents with recurrent episodes of pruritic erythematous plaques for the past 2 months. Each episode lasts for several hours and then resolves without treatment. She denies any new medications, foods, or recent illnesses. What is the most appropriate next step in the management of this patient? A. Initiate oral corticosteroids. B. Perform skin biopsy. C. Prescribe second-generation H1 antihistamine. And D. Order extensive laboratory tests. What's the correct answer? Dr. Ronin says, I want to choose A. Recurrent episodes of pruritic erythematous plaques for the past 2 months. Each episode lasts for several hours and then resolves without treatment. She denies any new medications, foods, or recent illnesses. What's the most appropriate next step in the management of this patient? And the correct answer is C. You want to prescribe a second-generation H1 antihistamine. Okay, second-generation H1 antihistamine. So the answer is C. So a second-generation H1 antihistamine, we recommend as first-line therapy for urticaria. So this patient is presenting with symptoms of urticaria, recurrent episodes of pruritic erythematous plaques for the past 2 months, okay? And each episode lasts several hours and then it resolves without treatment. You want to give your second-generation H1 antihistamine. That is C. Okay, now oral corticosteroids are reserved for cases with prominent angioedema or persistent symptoms despite antihistamine treatment. Okay, and then why will you not want to just do a skin biopsy right away? A skin biopsy is not typically necessary for diagnosing urticaria, unless there are signs and symptoms suggestive of vasculitis. That is when you want to do your skin biopsy. All right. And then extensive laboratory tests are usually not indicated. Like if the patient has urticaria, they have urticaria. Just give your second-generation H1 antihistamine and then you move. Doctors, before we move on, how is the class going? How is the class going? How is the class going? Let me know. Let me know. Let me know. How is the class going? Because I want us to touch on a lot of different things under this particular topic. And then we move into the rapid active recall, concepts under anaphylaxis and allergic reactions. Then we do that as well. Okay. All right, good. So candidates say going good, awesome. That's good. Okay, so let's move on. So you have a 40-year-old female with refractory chronic urticaria and episodic abdominal pain. Reports a family history of similar symptoms. What's the most likely diagnosis? A. Hereditary angioedema. B. Chronic spontaneous urticaria. C. Drug-induced angioedema. And D. Idiopathic mast cell activation syndrome. What's your answer? I go with hereditary angioedema, chronic spontaneous urticaria, drug-induced angioedema, or idiopathic mast cell activation syndrome. So before we move on, I think I've seen a question here. Doctors University says, which question bank do you think is best? Number one, for me, the question bank I will suggest you do is the Medical Council of Canada's own questions, which they sell on their website, right? Please go there, use that resource, buy it, do it. I think they have 115 questions for one set. They also have 230 questions for another set. That gives you a better view of what the exam is all about. You can also use UWorld. You can use ASQ Bank as well. Okay, and there are a lot of other question banks. For me, what I would suggest is expose yourself to as many questions as possible, because now it's an MCQ exam, right? So this is a message from Dr. Ronin. Dr. Ronin says, I did their test, very helpful. So I'll suggest it, please, kindly, if you have if you want to really prepare very well for this exam, don't hesitate to, do the MCC's own tests. Very, very, very important. Okay, good. So let's come back to this question. What is the most likely diagnosis? The most likely diagnosis will be A. It's hereditary angioedema. Okay, hereditary angioedema. Hereditary angioedema. What characterizes that? It is characterized by, if you want to see the diagnosis of hereditary angioedema, it is characterized by chronic urticaria. The patient may also have episodic abdominal pain, family history. So if you see that cluster of symptoms, chronic urticaria, episodic abdominal pain, and family history, is the most likely diagnosis. Okay, and the incorrect answers are the chronic spontaneous urticaria, drug-induced angioedema, because drug-induced angioedema lacks a familiar pattern, but this question was saying that this patient has a strong family history of the symptoms. Okay, and idiopathic mast cell activation syndrome would not explain the strong family history. Okay, so another point from Dr. Ronin, who took the MCC's mock exam, says the tests vary to some degree. I assume I'll see some of the questions on the exam in some form. Well, Doc, because it's coming from the Medical Council, I think that at least it will give you a better picture, right? A better picture of what the exam is all about. So please, if you can go take the mock exam, that would be very, very helpful for your preparation. Okay, good. Let's go to the next question. We have a 29-year-old woman develops severe urticaria and angioedema 12 days post Moderna mRNA COVID-19 vaccine. Labs show normal complement levels and negative autoimmune markers. What is the best next step? What is the best next step? A. Skin biopsy. B. High-dose corticosteroids. C. High-dose antihistamines. D. Serum tryptase measurement. Severe urticaria and angioedema 12 days post Moderna mRNA COVID-19 vaccine. Okay, normal complement levels and negative autoimmune markers. What is the best next step? This one I'm very happy because I see various answers. Skin biopsy, high dose corticosteroids, high dose antihistamines, serum tryptase measurement. What's the correct answer? The correct answer is C. And I see a lot of MedCognito students, Dr. Ben Ogu, Dr. Ronnie Lankela, all of them getting it right. That's great. Dr. Kusobaba also sent me a WhatsApp with his answer, saying the answer is C. So high-dose second-generation antihistamines are the first-line treatment for vaccine-associated urticaria. So please write that down in your book. If you have a patient with vaccine-associated urticaria and angioedema, think about high-dose antihistamines. Okay, high dose antihistamines. Second generation antihistamines are what you want to give. Okay. Now, I have this other question for you. A 32-year-old man with a known allergy history. Sorry, allergy to bird pollen, experiences itching of the lips and mouth after eating fresh apples and carrots. He has no symptoms when these foods are cooked. What's the most appropriate management strategy? A, avoidance of all forms of apples and carrots. B, referral to an allergist for desensitization. C, advising the patient to eat only cooked forms of these foods. And D, prescription of an epinephrine auto-injector. What's your correct answer? Is it A? Is it B? Is it C? Or is it D? Doctors, don't forget that this is just the first part of the class today. After this, we're going to do active learning of like anaphylaxis itself, where I'll pose the question and you will tell me the answer so that I know that whatever we've gone through sticks. Okay. So I see a lot of people go with C. A lot of people are going with C, and that's the correct answer. The patient likely has oral allergy syndrome, which we've learned already. Usually the patient has allergic rhinitis, and then the patient develops lip swelling after eating fresh fruit, okay? And it is characterized by itching and mouth swelling of the mouth after eating raw fruits and vegetables. Now, cooking the food denatures the proteins responsible for the symptoms, and it makes them safe to eat. So, advising the patient to eat only cooked forms of these foods is the most appropriate answer. Okay, so avoidance of all forms of apples and carrots is wrong, because if the food is cooked, it helps. And a referral to an allergist for desensitization is typically not required for oral allergy syndrome. All right, and then prescription of an epinephrine auto-injector, this is not indicated unless there's a risk of anaphylaxis, which is rare in oral allergy syndrome. Okay, so next one is, you have a 7-year-old boy with a known peanut allergy, presents to the emergency department with wheezing, coughing, and vomiting after arriving home from school. Now, his mother reports he was well in the morning and received no calls from the teacher during the day. On examination, he's flushed and has scattered urticaria on his neck and his axilla. Further questioning reveals that he shared a candy bar on the bus ride home. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? A, asthma exacerbation. B, acute urticaria. C, anaphylaxis. D, acute gastroenteritis. What's the right answer? So the answer is anaphylaxis. That is C, right? The presence of wheezing, coughing, vomiting, flashing, and urticaria after ingestion of a candy bar in a patient with known peanut allergy strongly suggests anaphylaxis. All right? So this is how anaphylaxis presents. But when we are doing the active recall, I'm going to show you the 3 ways anaphylaxis can present, so that you don't say that, oh, anaphylaxis has only one way of presenting. No, in a board exam, anaphylaxis can present in 3 different ways, and I'll show you. Okay, good. So you have a 16-year-old boy with a history of peanut allergy, accidentally ingests a peanut containing snack and administers epinephrine immediately. Which of the following should be which of the following steps should be taken next? So A, so this question is like, the next best step type question, right? He should stay at home and monitor his symptoms. B, he should take an oral antihistamine and rest. C, he should be transported to an emergency facility for observation. D, he should drink plenty of fluids to flush out the allergen. So you have somebody, he already has an EpiPen at home. He took something which would cause anaphylaxis. He injected himself. What should he do again? So in other words, this question is basically questioning you on what should you do after you've administered epinephrine in an out of hospital situation. Can you stay home? Can you just take an antihistamine? Should you necessarily be transported to a hospital, or should you just drink a lot of water and flush out the allergen? And the correct answer is C. He should be transported to an emergency facility for observation. So the teaching point is this: if you've been given IM epinephrine for anaphylaxis, the patient must be taken to the emergency department. Why? Because anaphylactic reactions can have a biphasic presentation. So it can come now, you can give your epinephrine, the symptoms can go down, and then it can come up again. That is why you want the patient to be sent to the emergency department, right? And then during the active recall class, I will quiz you on what is the duration you want to keep a patient who needs to be observed in the emergency department after anaphylaxis. Okay, so he should be transported to the emergency facility. Why? Because anaphylactic reactions can have a biphasic presentation. Okay, so you have a 25-year-old woman with a history of shellfish allergy, experiences difficulty breathing and chest tightness while eating at the seafood restaurant. Now, she does not have any epinephrine auto-injector with her. What's the most appropriate immediate action? A. Drink water to dilute the allergen. B. Leave the restaurant and seek medical attention. C. Call emergency services and seek immediate medical attention. D. Take an over-the-counter antihistamine. So you realize that this is the typical situation where you may be able to rule out two cases, and then now you have one, like two answers which look very similar, and go like, oh my God, what do I do? Right? So this is one of such situations. What is going to be your answer? Are you going to tell the patient to leave the restaurant and seek medical attention, or you are going to call emergency services, EMS, and seek immediate medical attention? So the answer is C. So Dr. Ronin was saying it seems emergent. Yes. So therefore you call EMS and seek immediate medical attention. Immediate medical attention is critical in the event of anaphylaxis, especially without access to epinephrine, right? Because you don't want the patient to just go. And the statistics tell us that majority of fatalities in anaphylactic reactions usually occur in the first 1 hour. So, just telling the patient to go, is the patient going to drive on their own? You don't know what's going to happen on the road. My goodness, that is bad. So just call EMS. EMS can come in and then they can help salvage the situation for you. Okay. So, doctors, that is the 1/3 part. Okay. Then we are going to enter the 2/3 before we go to the last part. Okay. Please, has this class been helpful so far? Have you been able to master your concepts very well? I just want to know, have you been able to master your concepts very well? Because we are going to another level where we're going to master differentials of anaphylaxis and allergic reactions. And we're going to do that with questions as well. Okay. Awesome. Okay. So let's go. Let's go. Let's go. Let's go. The 35-year-old female with no significant medical history presents with sudden onset of dyspnea, wheezing, and throat tightness after being stung by a bee. Her blood pressure is 90/60 millimeters of mercury. Her heart rate is 110 beats per minute, and she has generalized erythema. Which of the following statements is true regarding her condition? A. She is most likely experiencing an acute asthma exacerbation. B. Her symptoms are indicative of vasovagal syncope. C. Her presentation is consistent with anaphylaxis. D. She's experiencing a panic attack. E. The symptoms suggest a myocardial infarction. And so the correct answer here is C. The presentation is consistent with anaphylaxis. Okay. So when do you see, or when do you think about anaphylaxis? It is indicated by the rapid onset of symptoms in multiple systems. So it can be respiratory system, cardiovascular system, it can be in the skin. and usually it follows an allergen exposure like bee sting. Okay, and the symptoms usually include dyspnea, hypotension, generalized erythema. Okay, so now acute asthma exacerbation primarily involves respiratory symptoms without hypotension or generalized erythema, and that is why acute asthma exacerbation is wrong. And vasovagal syncope is characterized by transient hypothermia and fainting, and usually the patient may present with some pallor, okay, but most of the time there's no respiratory distress. And panic attack may cause dyspnea and tachycardia, but not hypotension. So the patient, I'm afraid, right? Panic attack, right? And myocardial infarction may present with chest pain, dyspnea, hypotension, but it is less likely to cause generalized erythema and or may be triggered by bee sting. So that is why anaphylaxis was our correct answer there. Okay. Next question. You have a 40-year-old male with a history of hypertension, presents with sudden collapse, diaphoresis and bradycardia after receiving an injection of penicillin. His blood pressure is 70/40. There is no history of known allergies. What should be the immediate management step? A. Administer oral antihistamines. B. Start intravenous fluids and administer epinephrine. C. Give sublingual nitroglycerin. D. Perform immediate defibrillation. E. Reassure the patient and observe. Sorry, I should have moved. I think I made a mistake on that slide. Let me see. Okay, there we go. This makes it better. This makes it better. So I see a lot of you going with start intravenous fluids and administer epinephrine. And that's the correct answer, right? This makes it very simple. Start intravenous fluids and administer your epinephrine. Next one. Next one. You have a 35-year-old female with a known history of anaphylaxis to peanuts who presents to your clinic for a follow-up after an acute anaphylactic episode. She was prescribed an epinephrine auto-injector but did not use it during her recent episode. Instead, using an H1 antihistamine and an asthma inhaler. What's the most appropriate advice to give her regarding the management of future anaphylactic episodes? A. Ensure to always carry an EpiPen auto-injector and use it immediately when symptoms of anaphylaxis appear. B. Rely on H1 antihistamines and asthma inhalers as they can effectively manage anaphylaxis. C. Wait until reaching the emergency department to use the epinephrine. D. Use the epinephrine auto-injector only if H1 antihistamines and asthma inhalers are ineffective. What's the correct answer? What's the correct answer? What's the correct answer? So I see a lot of doctors going for A. You want to ensure to always carry an epinephrine auto-injector and use it immediately when symptoms of anaphylaxis appear, right? So epinephrine is the first line treatment for anaphylaxis, and it should be administered as soon as the symptoms appear. Remember that H1 antihistamines are adjunctive treatments. Even steroids are given because of the biphasic reaction, right? So give your epinephrine as soon as anaphylaxis occurs, and delaying the administration of epinephrine is not very good. Okay. Next one is you have a patient with a history of severe anaphylaxis to insect stings and is concerned about future episodes. Which of the following strategies is most appropriate for reducing their risk of recurrent anaphylaxis? A. Carry H1 antihistamines and an asthma inhaler at all times. B. Undergo allergen-specific immunotherapy for insect stings. C. Using angiotensin-converting enzyme inhibitors regularly, like using ACE inhibitors regularly. And D. Avoiding all outdoor activities to prevent insect stings. What should be your right answer? What should be the correct answer? So the correct answer is B. 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 So those who are going for D, no, rather B. 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 Undergo allergen-specific immunotherapy for insect stings, right? Because we can do that. And in the clinic, we see quite a number of people. They go to the allergist and then they come and we need to, give them some injections subcutaneously. And then, it's the desensitization process takes time, but it is done in Canadian practice. And so this is something I really, really want you to pay attention to. So allergen-specific immunotherapy is highly effective in preventing anaphylaxis due to insect stings, and it provides long-lasting protection, especially for individuals with high-risk profiles. So you want to do that, all right? You want to do that. Now, you have a 12-year-old boy with a history of food-induced anaphylaxis who presents for a routine follow-up. His mother reports they have difficulty ensuring he always has his EpiPen or epinephrine auto-injector at school. Which of the following measures is recommended to address this issue? A. Encourage the child to carry his epinephrine auto-injector in his backpack. B. Ensure multiple epinephrine auto-injectors are available at school and train school staff in their use. C. Rely on the school nurse to administer antihistamines if anaphylaxis occurs. And D. Advise the child to avoid eating at school altogether. Because if that happens, then there's no problem. So what's our correct answer there? Our correct answer is that you want to ensure, it's B. You want to ensure that there's multiple epinephrine auto-injectors which are available at school and train the school staff in their use. Okay? Because having multiple epinephrine auto-injectors accessible and training the school staff ensures prompt and effective treatment during an anaphylactic reaction. That's number one. And number two, it also takes away the issue of, am I sure the kid is carrying the EpiPen or not? Because then if the child has an anaphylactic reaction, you know that the teachers have been trained, they know where to find the EpiPen, and they can give it in school and then take the child to the emergency room right away. Okay, so you have a 50-year-old male with a history of cardiovascular disease and anaphylaxis to shellfish who presents to discuss his medications. Now, which of the following medications should be reviewed due to potential complications during an anaphylactic episode? This is a beautiful question. And I'll be doing some more teaching about this when we get to the third part. So you have a 50-year-old male with a history of cardiovascular disease, okay, and anaphylaxis to shellfish, presents to discuss his medications. Now, which of the following medications should be reviewed due to potential complications during an anaphylactic episode? A. Beta-adrenergic blockers. B. H1 antihistamines. C. Antacids. And D. Multivitamins. In other words, which of these drugs can be a problem with other medications you may give for a patient with anaphylaxis? The correct answer is A. It's beta blockers. Okay, beta blockers. There's a concern with beta blockers and epinephrine, and there's even a concern with beta blockers and glucagon. And I'm going to take my time and take you through that when we get to the third part of the class. Okay, so why is beta blockers the correct answer? Beta blockers can complicate the treatment of anaphylaxis. How? Because they can reduce the effectiveness of epinephrine and increase the severity of the anaphylactic reaction. So beta blockers can have two effects. Number one, they can reduce the effectiveness of epinephrine, and number two, they can increase the severity of the reaction. Number one, they can reduce the effectiveness of epinephrine. Number two, they can increase the severity of the reaction. So that's why beta blockers are a very important thing. So in your board exam situation, always remember, okay, what is the relationship between beta blockers and epinephrine and anaphylaxis? They can reduce the effectiveness of epinephrine and they can increase the severity of allergic reaction. Okay, now a patient with idiopathic anaphylaxis is concerned about unpredictability of the episodes. What's the most effective long-term management strategy for this patient? A, carry multiple H1 antihistamines and carrying multiple H1 antihistamines and using them at the first sign of symptoms. B, regular administration of oral corticosteroids to prevent episodes. C, carrying an epinephrine auto-injector and having a personalized anaphylaxis emergency action plan. D, avoiding all potential allergens without confirmed diagnosis. Without confirmed diagnosis. Is it A? Is it B? Is it C? Or is it D? What's the correct answer? And the correct answer is C. The patient should carry epinephrine auto-injector and have personalized emergency anaphylaxis action plan. That's also something we do in Canadian practice. So if you have a patient who goes to the emergency room with anaphylaxis, we make sure that before the patient leaves with a prescription of auto-injectors if the patient is stable, and then we also give an anaphylaxis management plan as well. Okay, so doctors, we have finished the second part as well. Now I'm going to get to the active recall part, where we will use that to cement the concept of anaphylaxis. Please, has the class been helpful so far? Has it been helpful? We finished the first part and then we went on to differentials and some management, and then now we're coming back to now cement the concept so that we will know that, look, you've really mastered this thing. And doctors, if you want to get the best out of some of these things, that is why we also conduct the live classes, right? That's why we conduct the live classes, and so far the doctors in there are really enjoying it, especially for those who are going for the April and May exam, because what we also did for them is that we are doing a rapid review. So we stopped the system by system review, and then we have been doing back to back reviews as well. I think the last one will end on May 8th or so. Yeah, so tonight as well, we have another rapid review class, and that is why we are seeing results like some of our candidates getting 301, right? And so in MedCognito, what are you actually going to get, doctors? You're going to get a line upon line review of all the concepts, and that's can easily go for 1,997. Okay, but we also have 14 live classes every month, at least 3 hours each. And so if you do the calculation, we are doing 42 hours of tutoring every month for you. So it's not like a course where you are just doing your passive learning. No. You have your stuff on your portal, and then we also take you line by line. So if we take cardiovascular issues, like the way I'm teaching here, that's the same way we go through it, And then Dr. Isaac says, very helpful. And then this Dr. Abidoye, who is a MedCognito candidate, says, yes, so many people don't really know what MedCognito offers, and that is why I've taken my time to really share this. Dr. Salim also says, yes, very helpful. So you also get mock exams. So there are mock exams in your portal, which you can do at any time. That one, you don't need an invigilator. But we also conduct mock exams every 2 weeks. That one is a live mock exam. Another doctor says, yes, Dr. Broni's class is the best for QE1. Well, that's the truth. For me, I always tell people that if I was supposed to go for a QE1 class in this modern time, especially with all the changes, you want a tutor who cares. Number one, you want a tutor who has been through the process. You also want a tutor who will carry you along. So whether you are starting today or you started last month, you're good to go. Dr. Mwajon from Nigeria says everyone should be part of these classes. It's a must. Thank you, Dr. Mwajon. That's awesome. So doctors, these are real people who are experiencing real results from what MedCognito is offering. Okay, and then you also have an interactive personal study portal, which you can open on your laptop. So if you open on your laptop, you have all these options and even more, right? So if you're going to do an otorhinolaryngology class in the evening, you can sit down, review everything, and then come to the class and then just walk through the whole thing. And then we also have med bullets. So beyond all these things, we have med bullets. Now, med bullets is, I really wish that one of the MedCognito candidates can describe med bullets, but med bullets is basically what we did was like, you know what, you've learned all these concepts. You've learned all these concepts. What do you do? So every 10 minutes, you review 10 topics. And the last time we did it, we have 2,700 topics, but we've even increased it to now 3,400. Okay, so please, the MedCognito candidates, kindly go to your family medicine portal, open MedBullets. You realize that we've increased the number, right? And that is what you will need to get through the program. And then now we've even added what we call med drills. Okay, so we have med bullets, which it's like I'm speaking into your brain. rapid review with you. And then we also have med drills. So we have two different things: med bullets, med drills, right? And that is also on top of the live classes you are doing. And so that is why success is the goal. Success is the goal, because we just want to see you at the end of the game. Okay, and this has all been reduced from like 7,860 to just 2,199. Doctors, this is a good use of your time. You have two options: either to study on your own or to come to a place where people are being supported day in and day out to achieve their dream. Okay, so I just want you to know that I'll be sharing the link to register, or you can even reach out to me at +1 306 891 5649. +1 306 891 5649. I don't know. This Dr. Omojon from Nigeria says something. She says, med bullets, rapid fire of every single information in medicine that you require for the exam. She says, sharp. Yeah, that is it. So can you imagine? You have 3,400 topics reviewed for you in family medicine alone, right? And this is just rapid review of stuff. And then you also have the systems: cardiology, otorhinolaryngology, ophthalmology, and then you also have live classes. And then you also have med drills, where we come in to drill you. And then you also have mocks in your portal. And then you have live mock exams. Doctors, it does not get any better than that. Okay, we want to make sure we've covered all the basics. Okay, so let's get into active recall now. Let's get into active recall. So if you are interested, my number is what is rolling under the screen: +1 306 891 5649. Just send me a WhatsApp after this class. I'll call you and then we'll get the ball rolling. Okay, +1 306 891 5649. +1 306 891 5649. Now let's do active recall to cement the concept of anaphylaxis. So how is anaphylaxis actually diagnosed? You've got to know that there are 3 different ways a patient can present in an MCQ format. And you don't need to be tricked. Many of us have the throat issue, the skin rash, and the shortness of breath. That is what many of us know, right? But then there are 2 other ways anaphylaxis can be presented in an exam. And I'm taking you to the first one. So the first definition you need to know is there's an acute onset of an illness, which is usually minutes to hours, with involvement of the skin, okay, and or the mucosal tissue. So look for a patient who just developed acute reaction, and the patient is described as either having hives, urticaria, pruritus, flashing, swollen lips, or swollen tongue, or the uvula. And then there is also associated symptoms with either there's respiratory compromise, where the patient is dyspneic, has wheezing, has stridor, or reduced blood pressure, or there's associated organ dysfunction. So let me take it again. The first definition that many of us know is that, the patient was exposed to something, and then after the patient was exposed to that thing, there's a skin rash, okay? And then there can be effects in other systems like the respiratory system, the cardiovascular system, or an organ dysfunction where the patient may present hypotonia, syncope, even incontinence. Okay, even incontinence. So this is the first definition. Okay, and Dr. Dogwa says this is a treasure. Yeah, we are opening the treasure for everybody. Everybody should be able to get it, because for a long time, people come in and they just pick books, popular books, which are very good, right? But then they don't know how to study for the exam itself. And doc, it's not enough to just read books. In fact, on Friday, I had a conversation with somebody who was saying, Dr. Bruni, I didn't want to solve any questions, and so I was just reading books. I was like, no, doc, that is not the right strategy, right? And even when you're reading the books, you need to know exactly what you are learning in those books. And that is all that we've done for you. So basically, you just have to sit down and absorb what we've given you. And that is it, okay? So somebody asks, is MedCognito more than enough? Doctor, it is more than enough, and I can say it without any shadow of a doubt. MedCognito is more than enough. Okay, good. So that's the definition number one. Definition number two is that there can be two or more of the following that occur rapidly after exposure to a likely allergen: involvement of the skin or mucosal tissue, respiratory compromise, reduced blood pressure, or its associated symptoms. So the patient may become dizzy, lightheaded, okay? And then there can be persistent GI symptoms as well. So these are the things I want you to pay attention to, where the patient can have abdominal cramping or vomiting. And the third definition is that you should suspect anaphylaxis when patients are exposed to a known allergen and they develop hypotension. Okay, they can develop hypotension. So patients took peanuts and developed hypotension. That's anaphylaxis. The patient may not have any skin reaction. The patient may not have any wheezing. The patient may not have any throat tightening. Allergen plus hypotension is also anaphylaxis. Three ways of defining it. Okay, now what's the difference between anaphylactic reaction and an anaphylactoid reaction? This one, I want you to write your answer in the comment section. What's the difference between anaphylactic reaction and anaphylactoid reaction? Because I want you to be able to pick up an anaphylactic reaction, and then I also want you to pick up an anaphylactoid reaction if I'm giving it in an MCQ. But because MCQs, you can even guess, that is why I'm introducing this way of quizzing candidates: anaphylactic reaction versus anaphylactoid reaction. Let me use this opportunity to teach it. Doctors, I have a question. This active recall, do you think it's going to help you, or you just want us to just do MCQs? Do you want MCQs plus active recall like what we are doing, or you just want MCQs alone when we are doing these sessions? Just let me know. So do you want active recall plus MCQs, or you want just MCQs only? Okay, Dr. Ronin says yes, but Dr. Ronin, I don't know which one you want. Okay, so Dr. Tier says both. Okay, both. Okay, good. So what's the difference between anaphylactic reaction and an anaphylactoid reaction? Because you don't want to confuse them in an MCQ, okay? So an anaphylactic reaction is an IgE-dependent reaction. But anaphylactoid reaction is IgE-independent reaction. Please take note. So if you see the word anaphylactoid reaction, it is an IgE independent, and anaphylactic is IgE dependent. Remember that we said anaphylactic reactions usually occur, it's a type 1 hypersensitivity, and we talked about type 2 hypersensitivity, type 3 hypersensitivity, type 4. We learned that IgE mediated reactions, usually they are immediate. Meanwhile, type 2, type 3, and type 4 are delayed, right? And type 4 is T-cell mediated. We learned that as well. Okay, next one. What are the most common provoking factors for anaphylaxis? Let's review the top 4 classes. Most common provoking factors for anaphylaxis. You must also, most common, next best step, right? What's the next immediate step? Those things. That's why I'm trying to quiz you on these things. So The 4 classes of anaphylaxis triggers are foods, medications, insect stings, and allergen immunotherapy injections. Foods, medications, insect stings, and allergen immunotherapy injections. Okay, next one. Which medication class? Now look at this. This I didn't say which medication. Said, and this one I want you to type the answer. Which medication class is estimated to cause the highest number of deaths in developed countries from anaphylaxis? So doctors, remember that anaphylaxis is not just about, oh, you give EpiPen, you give IV fluids, and you go. No. In an MCQ situation, we can quiz you from various angles, right? We can quiz you from various angles. So which medication class? Medication class. Which medication class is estimated to cause the highest number of deaths in the developed countries from anaphylaxis? So someone is saying, is it aminoglycosides? Is it penicillins? The correct answer is beta-lactam antibiotics. Beta-lactam antibiotics. Please, these active recalls, I need you to write them in your box, okay? Because I've gone through everything you need to know about anaphylaxis from all your sources, up to date, Centenary, Rosson's, emergency medicine, every possible place you should be reading, which the medical counselor has suggested. I've reviewed everything for you, and that is how I brought out these active recall, things. Okay. So beta-lactam antibiotics. Okay, good. Name 5 important drugs that commonly cause anaphylaxis. Let's go. 5 important drugs that commonly cause anaphylaxis. So these ones you must know them, right? 5 important drugs that commonly cause anaphylaxis. The answers are beta-lactam antibiotics, antisalicylic acid, that is aspirin, trimethoprim sulfamethoxazole, vancomycin, and NSAIDs. These 5 top drugs that are commonly linked with antibiotics. Okay, sorry, let me take this question before we move on. So the doctor says, I want to ask about the TDM exam. Is there any break through the 3 hours and any resources to study from? I want to ask about it. So the TDM is what we call the therapeutic decision making. It's the exam for those who are going for the practice ready assessment in family medicine. So in Saskatchewan, we call that SIPA. So is there any break through the 3 hours? I don't know. Are you talking about our live classes that we conduct? Because we conduct TDM live classes every Wednesday, right? And we are conducting one and preparing the people for the upcoming TDM exam. So Doc, maybe you can talk to me on my WhatsApp so that we can just focus on QA1 for today, okay? When we are done, just call me on my WhatsApp, 306-891-5649, 306-891-5649, so that we can focus on the Q1 for today, and I'll really answer your question. Okay, please. Dr. Ahmed Gauda, please. This is the question. So, doctor, just send me a WhatsApp right now. After this, I'll just call you back. Okay, good. So, please write these down. Beta-lactam antibiotics, antisalicylic acid, that's aspirin, trimethoprim sulfamethoxazole, vancomycin, and NSAIDs. These are the 5 important drug classes that cause anaphylaxis. Then list 5 foods which are common triggers of anaphylaxis. 5 foods which are common triggers of anaphylaxis. And what are they? Shellfish. Okay, so in your MCQs, please look out for them. Soya beans, nuts, peanuts and tree nuts, wheat and milk. These are the 5 top common food triggers of anaphylaxis. Shellfish, soybeans, nuts, wheat, and milk. Shellfish, soybeans, nuts, wheat, and milk. Okay, next one. What's the second most common cause of anaphylaxis after medications? This is a very good question. Second most common cause of anaphylaxis after medications. Second most common cause of anaphylaxis after medications. Second most common cause of anaphylaxis after medications. And the answer is Hymenoptera stings. Hymenoptera stings. Like bee stings, wasp, hornet stings, right? So after medications like penicillin, the next common cause of anaphylaxis in adults is stings from insects, Hymenoptera, bee, wasp, hornet stings. Dr. Rockefeller says, can you flash the medication page again? Okay, sure. Let me go back. So beta-lactam antibiotics, acetyl acid, trimethoprim sulfamethoxazole, vancomycin, and NSAIDs. Okay, and NSAIDs. Okay. Doctors, please, are you picking up something? Are you picking up something like the way we are doing the active recall? It's just step by step by step. We're going to go through it so that we can just, yeah. Okay. So what is the leading cause of anaphylaxis in children? We've talked about adults, but what's the leading cause of anaphylaxis in children? In children. What's the leading cause of anaphylaxis in children? What's the leading cause of anaphylaxis in children? So Dr. Isaac said food, and that is it. Food allergies. That is the commonest cause of anaphylaxis in children. Next one. What type of cell plays a central role in the progression of anaphylaxis? What type of cell plays a central role in the progression of anaphylaxis? So you see, this one, I'm not giving you any options, so I can, because if you know it, then in a board exam situation, you can just go, oh, Dr. Bruni taught this. So what type of cell plays a central role in the progression of anaphylaxis? So some says mast cells. I think that's what Dr. Tir Miriam also saying. So the answer is mast cells. Beautiful. Okay. Name 5 major mediators responsible for pathophysiology of anaphylaxis. 5 major mediators. So that in a board exam station, if you know it, then when you are giving it in an MCQ, you can be able to just kill it, right? 5 major mediators responsible for the pathophysiology of anaphylaxis. 5 major mediators responsible for the pathophysiology of anaphylaxis. Five major mediators responsible for the pathophysiology of anaphylaxis. And I think I'm getting some messages from our NAC candidates. Says, please kindly summarize the anaphylaxis management plan for NAC purposes too when you are done. Okay, sure. I'll do that. So they want me to, you see, some NAC candidates are also coming for QE1 class. Do you know why? Because QE1 and NACOSCI all cover the same objectives, and in fact the TDM as well. So yeah, that's why it's good to make sure that your knowledge is solid, right? So name 5 major mediators responsible: histamine, prostaglandin D2, leukotriene, platelet activation factor, and tumor necrotic factor alpha. So doctors, please note these things. Histamine, that's why you can give antihistamine, prostaglandin D2, leukotrienes, platelet activation factor, and tumor necrotic factor alpha. Let me say it again: histamine, prostaglandin D2, leukotrienes, platelet activation factor, and tumor necrotic factors. Okay, good. Next one. What are the 2 organ systems often compromised in severe anaphylaxis? 2 organ systems often compromised in severe anaphylaxis. I want you to know, so that if I give you options, you know the answer already. So literally, what we are doing is we are reverse engineering the whole thing, right? If you know it, then when it's given in options, you go like, oh, Dr. Bonnet taught this. Okay, so Dr. Luke is saying cardiovascular and respirology. Dr. Tim is also saying the same thing. Dr. Ben Ogu is also saying the same thing. So it's respiratory and cardiovascular systems. Beautiful. So these are the 2 organ systems often compromised in severe anaphylaxis. Next one. What are the major clinical signs of systemic allergic reactions? What are the major clinical signs of systemic allergic reactions? I'm very happy about, the participation, because, and so this is what we'll be doing. The second part of all these live classes will also be doing active recall, right? So that I will really be able to know whether you know it. So what are the major clinical signs? Diffuse urticaria and angioedema. Okay, the major clinical signs. Remember that we said in the first definition, we said that most of the time the patient has skin-related symptoms, and then they can also have like some throat tightening, right? So what are the major clinical signs? Diffuse urticaria and angioedema. Next one, list at least 5 additional symptoms that can accompany urticaria and angioedema in anaphylaxis. So apart from the angioedema the patient may present and urticaria, what are other symptoms that can accompany urticaria and angioedema in anaphylaxis? Okay, what are other symptoms? Doctors, thank you very much for contributing. It allows the class to move well and we get the best out of it. So the patient can present abdominal pain and cramping. Remember, that was the second definition. The patient can present with nausea. The patient can present with vomiting. The patient can present with diarrhea. The patient can even present with bronchospasm. The patient can even present with rhinorrhea, conjunctivitis, even abnormal heart rhythm, that's dysrhythmias, and hypotension. If you remember the third definition, we said that if a patient is exposed to an allergen and develops hypotension, that on its own qualifies as a definition of anaphylaxis. Okay, that on its own qualifies as a definition of anaphylaxis. Okay, now what's the classic initial presentation of anaphylaxis? So doctors, we are just bombarding ourselves, right? What's the classic initial presentation of anaphylaxis? And the correct answer is the patient may have pruritus, initial presentation, cutaneous flushing, and urticaria. Pruritus, cutaneous flushing, and urticaria. All right, awesome. That's the initial presentation. So most of the time in anaphylaxis, the initial presentation is like a cutaneous presentation, skin-related presentation, pruritus, itchy skin, the body, I'm itching, cutaneous flushing and urticaria. Now, which symptoms typically follow the initial cutaneous signs of anaphylaxis? So after the patient has the initial skin signs, which symptoms typically follow? Which symptoms typically follow? And the correct answers are a sense of throat fullness. That's why they develop the angioedema, anxiety, chest tightness, right? Shortness of breath, and lightheadedness. Oh, I'm woozy. Oh, I'm woozy. Like that kind of thing. So lightheadedness as well. So they get a skin things, angioedema, throat, then, and like, they feel that something is happening, anxiety, chest tightness, shortness of breath, lightheadedness. Okay, now what serious events can occur as the anaphylactic cascade progresses? What serious events can occur as the anaphylactic cascade progresses? The patient can develop decreased level of consciousness. They can then develop respiratory distress. They can then develop circulatory collapse. And if we are not careful, they can develop cardiorespiratory arrest, and then they can die. Decreased level of consciousness, respiratory distress, circulatory collapse, cardiorespiratory arrest, and then they can die. All right? Okay. So how soon do the signs and symptoms of anaphylaxis usually begin after exposure? How soon do the signs and symptoms of anaphylaxis usually begin after exposure? How soon? This one, I want you to give me an answer. I'll wait for your answers. I'll wait for your answers. How soon? How soon? How soon? How soon? How soon? How soon? Someone says second to minute. Yeah. So within 60 minutes, right? Within 60 minutes. Within 60 minutes. Within 60 minutes. You'll see the symptoms within 60 minutes. Remember, it's an IgE mediated response, and usually it's acute. Okay, so name at least 4 conditions included in the differentials of anaphylaxis. Name at least 4 conditions included in the differentials of anaphylaxis. Name 4 conditions included in the differentials of anaphylaxis. So they can have vasovagal reactions, they can have myocardial ischemia, because there can be cardiovascular compromise, they can have arrhythmias, status asthmaticus, right? They can develop even a seizure, epiglottitis, hereditary angioedema, foreign body airway obstruction, carcinoid syndrome, mastocytosis, vocal cord dysfunction, and non-IG mediated drug reactions. Okay, so if you are talking about the differential diagnosis of anaphylaxis, these are all other differentials that a patient can also exhibit. So anaphylaxis, if you're not careful, you may confuse it, right? So these are all differentials of anaphylaxis: vasovagal reactions, myocardial ischemia, arrhythmias, status asthmaticus, seizure, epiglottitis, hereditary angioedema, foreign body airway obstruction, carcinoid syndrome, mastocytosis, vocal cord dysfunction, and non-IG mediated drug reactions. And we learned today that the IG mediated ones are what you call anaphylaxis, and the non-IG mediated ones, please, what's the name? Can you type the answer for me? What is the name? Non-IG mediated. Non-IG mediated. Beautiful. Dr. Ode says anaphylactoid, 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 anaphylactoid. Okay, anaphylactoid. Beautiful. Next question. Do laboratory tests play a major role in the acute diagnosis of anaphylaxis? Somebody comes in, anaphylaxis, we give our EpiPen, everything. Do we need to do any labs? Anaphylaxis, do we need to do any labs? There and then. Anaphylaxis, do we need to do any labs? Beautiful, beautiful. No, people are saying no. Yeah, no, they have very limited role. Very limited role. No, don't do it. Okay, now I turn the question. What laboratory marker can be elevated for several hours after anaphylaxis? Patient has had anaphylaxis. We are not doing any labs right now, but after several hours, we decide to do one unique lab. What laboratory investigation do we want to do? What laboratory investigation do we want to do? What laboratory investigation do we want to do? And it is elevated for several hours after anaphylaxis. What one laboratory investigation do we want to do? And it's elevated after several hours after anaphylaxis. And the correct answer is serum tryptase. Serum, beautiful. Dr. Titilope, awesome. That is good. She got it. Serum tryptase is the correct answer. Dr. Titilope, which source were you reading this from? Let me know. Just type it in the comment section. She's a MedCognito candidate. Type it in the comment section. I really want to know. I want to make you popular. So Dr. Titilope is from Nigeria. Serum tryptase. That's beautiful. That's a very good answer. So this laboratory marker is elevated several hours after anaphylaxis. Beautiful. So look at that. She said she read it from uptodate.com. UpToDate. So doctors, let me tell you something. The main resource that the Medical Council wants you to use in your reading, emergency medicine, I always tell you, is Tintinali. Okay? Tintinali or Rossins. Tintinali is what those who are doing family medicine with +1 in emergency medicine use, and Rossins is what those who are doing a 5 years emergency medicine program use. Okay, and I think that should be fine. Or you can just use UpToDate for all your references, and that is fine. So the laboratory marker, which is elevated for several hours after anaphylaxis, is serum tryptase. Beautiful, Dr. Titilope. Good, 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 good. 2 thumbs up for you. That's great. Okay. What is the single most important step in the treatment of suspected anaphylaxis? This one you should know. This one you should know. Quick one, quick one. What's the single most important step in the treatment of suspected anaphylaxis? Single most important step in the treatment of anaphylaxis. Single most important step in the treatment of anaphylaxis. Dr. Titilope, seriously, I'm very, very proud of you. Good. epinephrine IM, epinephrine IM, epinephrine IM, rapid administration of epinephrine. And I should have even added IM. Dr. Tislope is making Nigeria proud. I'm so happy. I'm so happy. I'm so happy. You know, my country of origin is Ghana, right? And we always have something we have with Nigerians. We are brothers and sisters, but there's something we fight over. It's called jollof rice. So if you don't know about that war between Ghana and Nigeria, please read about it. Jollof rice. It's some nice rice that we are very good friends. But when it comes to jollof rice, come on, we fight in a nice way. Okay, good. So so what are the 3 first line priorities in emergency management of anaphylaxis? Emergency management of anaphylaxis. What are the 3 first line priorities? I'm very happy that we introduced the active recall because this is very, very good. What are the 3 first line priorities in emergency management of anaphylaxis? Beautiful. Dr. Rollins says A, B, C. So it's airway, breathing, circulation. That's our 3 first line priorities in anaphylaxis: airway, breathing, and circulation. Beautiful. What are the 3 first line therapies for anaphylaxis? So we've moved from priorities to therapies. 3 first line therapies for anaphylaxis. Yeah, Dr. Thomas, that war, even the UN cannot stop it. My goodness. Jollof rice from Nigeria, jollof rice from Ghana, we will fight so that kingdom come. Okay, 3 first line therapies in anaphylaxis. What are they? First, epinephrine. Next, IV fluids. Next, oxygen. Please remember these 3. Give your epinephrine IM, get your oxygen thrown on, give your fluids because the patient can be hypotensive, right? Epinephrine, IV fluids, oxygen. Epinephrine, oxygen, IV fluids. But give your epinephrine, please. Give it. Don't stop it. Just give your epinephrine. Okay. Next one. What signs in the airway should prompt early intubation in anaphylaxis? Now we are getting into deep stuff, right? What signs in the airway should prompt early intubation in anaphylaxis? So, doc, that's what I'm saying, that your learning should be straightforward and targeted. After you pass the exam, you can attend all the conferences on anaphylaxis in the world, right? But you need to make sure that you've mastered the concept so that no question on anaphylaxis can beat you. And that is what we are doing today. So what signs in the airway should prompt early intubation in anaphylaxis? So someone says edema. Someone also says bronchospasm. The correct answer is if there are any signs of angioedema. So if there's uvular edema, if there's stridor, if there's respiratory distress, if there's hypoxia, please prepare for intubation. Please prepare for intubation. If there's signs of angioedema in the context of anaphylaxis, next best step, after you've given your IM epinephrine, boom, prepare for intubation. Okay, good. Now, how should a stinger be handled after an insect sting? So the patient was stung by a bee. The patient has developed anaphylaxis. You've given your epinephrine. What do you do? What do you do to the stinger? What do you do? What do you do to the stinger? What do you do, doctors? What do you do to the stinger? How should a stinger be handled after an insect sting? What should you do? What should you do? Tell me. What do you want to do? What do you want to do? After an insect sting, what do you want to do? How do you want to handle the stinger? Good. So remove any stinging remnants quickly. Because if you leave it there, constantly, giving the venom or the allergen into the patient's body. Okay. What's the recommended IM dose of epinephrine for adults during anaphylaxis? Remember that, like in the Q1, you don't really need to learn medication doses, but if there's one medication you need to know the dose, it's epinephrine dosing for adults. Okay, what's the recommended IM dose? recommended IM dose of epinephrine for adults during anaphylaxis. Epinephrine dose of epinephrine during anaphylaxis in adults. And the correct answer is you want to give 0.3 to 0.5 milligrams IM. Okay, 0.3 to 0.5 milligrams IM. And usually do the so that comes to 0.3 to 0.5 mils of the 1 in 1,000 dilution. Okay, and you can repeat it every 5 to 10 minutes if needed. No. Dr. Chiagozi says, for intubation, do you intubate before IM epinephrine? No. Patient comes in, you suspect anaphylaxis, just jab the person with epinephrine. Give it. Don't waste any time. And remember that you can even repeat the IM epinephrine every 5 to 10 minutes because it takes time to organize your rocuronium, all those things for intubation, like to get your light and position the patient's neck. But you could have just given the IM epinephrine quickly, and then you can start preparing for intubation. After 5 minutes, you've not intubated yet, patient is still not doing well, give another one, right? Now, next question. So I hope that was helpful. Why must caution be used when giving epinephrine to patients on beta blockers? Remember that when we're doing the part 2, I talked about it, right? Why must caution be used when giving epinephrine to patients on beta blockers? And the correct answer is because beta blockers can cause severe hypertension due to unopposed alpha adrenergic stimulation. So when you're giving epinephrine plus beta blockers, you want to be careful because it can lead to severe hypertension due to unopposed alpha adrenergic stimulation. Let me say it again. So that's one thing you want to pay attention to: beta blockers and epinephrine, right? We learned that there can be severe cardiovascular implications. Okay, good. Then when should you give IV epinephrine? When should you give IV epinephrine? Because we've talked about IM epinephrine, right? So, and remember that when we started the class, there were some questions where I was dropping IV epinephrine and all of you did not give it. That's good. But is there a situation where you need to give IV epinephrine? Is there a situation where you need to give IV epinephrine? And the answer is yes. You give IV epinephrine when the patient is refractory to IM doses or there is cardiovascular collapse. So the blood pressure is still dropping. Then you want to support the cardiovascular system, right? That's when you give IV epinephrine. Okay, so when the patient just comes in and the patient is stable, but the patient is having an allergic reaction, an anaphylactic reaction, just give your IM. But you give the first one, second one, oh no, the patient's blood pressure dropping 90/60. Hey, dropping, Dr. Noel, it's gone to now 80/40. Come on, it's gone to 6. Then the nurses are, Dr. Noel, what are you doing? Dr. Tislope, what are you doing? Dr. Tislope says, I attended the class. Please get us the IV epinephrine. Let's go. Let's give it right away. Okay. So when the patient's symptoms are refractory to IM doses and if there is cardiovascular collapse, give IV epinephrine. Okay. Now, name 4 second-line treatments used in anaphylaxis management. Remember that the first line treatment is epinephrine, IM epinephrine. But what are other second-line treatments we can use in anaphylaxis management? Second line. The correct answer is corticosteroids. Why do we give corticosteroids? I mentioned it to prevent the biphasic reaction, the delayed reaction. You can also give antihistamines. You can give bronchodilators like albuterol or salbutamol, and then you can also give glucagon. And why do we give glucagon? What's the relation between anaphylaxis and glucagon? You give glucagon in patients who are on beta blockers. Powerful. Yeah. So you give glucagon in patients with anaphylaxis who are also on beta blockers. Oh my. You give glucagon in patients who have anaphylaxis but who prior to presenting are also on beta blockers. So Second line treatments used in anaphylaxis: corticosteroids, antihistamines, bronchodilators, glucagon. Right? Good. Now, what is the target oxygen saturation when administering oxygen in anaphylaxis? So, doctors, you see, anaphylaxis is, yes, it looks simple, but in an MCQ situation, you need to know your stuff, right? But what's the target oxygen saturation when administering oxygen in anaphylaxis? The target is the patient's oxygen saturation be more than 90%. More than 90%. You want to get the oxygen above 90%. Okay, good. And what H1 blocker and dose are used in adults for anaphylaxis? Don't worry so much about the dose. Don't worry so much about the dose. Those who have to worry about the dose are those who are going for the therapeutic decision-making exam. Dr. Titilope, yeah, the answer, according to some literature, is more than 90 degrees. Okay. So what H1 blocker and dose are used in adults for anaphylaxis? And the correct answer is diphenhydramine, 20 to 50 milligrams every 6 hours. You can give it IV, you can give it IM, you can give it by mouth. Now, I put a caveat in the blue. Don't worry about drug doses for the MCQ one. The only drug dose you should really memorize is the IM dose of epinephrine. Okay, but I'm bringing this because at times we also have candidates who are taking the TDM exam who also watch the YouTube videos. And so if you're going to give diphenhydramine, you give 25 to 50 milligrams every 6 hours, and you can give it either IM, by mouth, or IV. Okay, good. Today's class has been different. I don't know, the vibe in the class today is different. It's very good. That's good. Okay. So when is glucagon indicated in anaphylaxis? I've already taught this. I want to know. Please, this one, type it in split second. Type it. Why is glucagon, or when is glucagon indicated in anaphylaxis treatment? When is glucagon indicated? Beautiful. If the patient is in beta blocker. So in beta blocker patients with hypotension, refractory to fluids, and epinephrine, that's when you give your glucagon. Okay, give your glucagon. Beta blockers. Beautiful. So doctors, you see, that's what I'm saying. There are things which are commonly known amongst us. Anaphylaxis, high epinephrine, give your oxygen, and that is it. And then when the patient is going home, give EpiPen. But if somebody decides to really quiz you very well, right, and go deep, these are some of the things which come up, and these are some of the things you need to master if you want to really nail this exam. Okay, now what are the major side effects of glucagon? Because we just talked about glucagon. What are the major side effects? You must know. Okay, so the major side effects can be nausea, it can be vomiting, it can be hypokalemia, it can be dizziness, it can be hyperglycemia. Okay, nausea, vomiting, hypokalemia. So remember, what is going down is potassium. What is coming up is glucose. Hypokalemia. So if you are tricked in the exam, hypokalemia, hyperkalemia, hypomagnesemia, hypoglycemia, you must know which one is which. Hyperglycemia and hypokalemia. Okay, hyperglycemia, major side effects of glucagon, and hypokalemia. Hyperglycemia and hypokalemia. Okay, now which bronchodilator is used for allergic bronchospasm in anaphylaxis? Can give you salbutamol, can give you albuterol. All right, doctors, please, can I move on? Can I go on? We've done almost 2 hours of learning. Do you feel that you've done 2 hours already? You know, do you feel that you've done 2 hours? This is interesting, right? We've done almost 2 hours. So which bronchodilator is used? Nebulized albuterol or salbutamol? Okay. And what medication can be added for severe refractory bronchospasm? So in other words, you've given your Ventolin, you've given your albuterol, but the patient still has severe bronchospasm. Which drug can you give? Which drug can you give? You can give ipratropium bromide, or you can give magnesium sulfate. You can give ipratropium bromide, or you can give magnesium sulfate. You can give ipratropium bromide or magnesium sulfate. So please watch it. Anaphylaxis. No question should beat you in anaphylaxis. And which patients with anaphylaxis should be admitted to the ICU? Because is it every patient who should go to the ICU? Remember that in the objectives, right? At times the medical council mentions indications for referral and indications for ICU admittance, right? So which patients need ICU admission? Number one, patients who are hemodynamically unstable. Number two, patients who are refractory to treatment. And number three, patients who require airway intervention. These are the patients you want to send to the ICU. Okay, refractory, unstable, and require airway interventions. And how long should a patient be observed in the emergency department after receiving epinephrine for anaphylaxis? How long? Tell me, how long should a patient be observed in the emergency department after receiving epinephrine for anaphylaxis? Please tell me, how long? How long should a patient be admitted or observed? Observed. So Dr. Michael Israel says 6 hours. Yes, Dr. Ronin, in hours. So someone says 6 hours. Dr. Laurie says 12 hours. Dr. Reyes says 12 hours. Dr. Saha says 2 to 4 hours. The answer is at least several hours after treatment. Typically 4 hours. Typically 4 hours. 4 hours. Typically 4 hours. If they are symptom free before you can discharge. Okay, because of that biphasic reaction. And when should prolonged observation? So we've learned that you give your IM epinephrine basic patient to be kept in the ER for 4 hours, right? But when should prolonged observation after anaphylaxis be considered? When should prolonged observation in anaphylaxis should be considered? When? Under what circumstances do you want to observe the patient beyond 4 hours, right? The answer is if the patient has a past history of severe anaphylactic reaction. So the patient has had severe anaphylactic reaction in the past. Number two, use of beta blockers. So if the patient had anaphylaxis and was also on a beta blocker, if the patient has severe comorbidities or significant comorbidities, maybe a patient with anaphylaxis who has, previous history of myocardial infarction, previous history of like poorly controlled diabetes, poorly controlled hypertension, those kinds of things. Maybe, a patient with anaphylaxis who is immunosuppressed, right? And then if the patient lives very far away from the medical center, then you want to keep the patient longer than 4 hours. And if the patient lives alone, as well as if the patient is older, advanced age. Doctors, please, are you tracking with me? Are we good? Are you tracking with me? Beautiful. This is good. Okay, what should be prescribed to patients at risk of recurrent anaphylaxis upon ED discharge? So this is where the NAC OSCE candidates were asking me, what do you want to prescribe to patients at risk of recurrent anaphylaxis upon emergency room discharge? You want to prescribe an epinephrine auto-injector. Epinephrine auto-injector. And you want to give, clear instructions about how to use it. Okay? Now, for the NAC OSCE candidates who are asking me as well, what patient education and support should be offered to anaphylactic patients? What patient education and support should be offered to anaphylactic patients? Number one, you want to give them educational resources. Number two, you want to refer them to advocacy groups for information. Number three, you want to instruct them on food contamination risks. And number four, you want to advise them to wear their medical alert bracelet. So for those who are in the NAC OSCE class who are asking about, what to do after a patient has come to the emergency room with anaphylaxis, these are some of the things you want to do. You want to refer them to educational resources, advocacy group for information, instruction on food contamination risks, and advise them to wear their medical alert bracelet. And tell them that, look, you want them to get multiple EpiPens, maybe 3. One in the house, one in their car, one in their bag, school bag, and then one at their workplace or school, wherever they spend a lot of time. And they should also get the people around them educated, so that in case the patient becomes anaphylactic and cannot give the epinephrine to themselves, those around him or her can do that. Now, what plans should patients have for future allergic exposures? They have to have a written action plan describing the steps to take in case of future allergen exposure or symptom development. Okay, so don't forget that they need a written action plan. So doctors, we coming down to the end of our class today. It's been awesome. Please, how are you going to ace the QA1? Kindly focus on the objectives. I beg you. I see so many people, and these are the important topics in family medicine. I'm like, no. That's not how we do it. Focus on the objectives. Focus on the objectives, doctors, please. From my heart, focus on the objectives, okay? Please. Focus on the objectives. Focus on the objectives. No, I'm not done there.
Are you coming to town?
Yeah, I'll come and then we'll go to town. Yeah. So my daughters just came around. They're asking me when I'm done. Because they've seen that daddy just spent 2 hours teaching.
Are you done?
Almost done. Please go. I'll be with you. Okay? Doctors, please, I beg you. We say all these things from our hearts. I'm committed to your success. Okay? I am. Trust me. So just reach out. This is my phone number. +1 306 891 5649. +1 306 891 5649. And thank you very much, doctors, for all the wonderful messages. Someone just sent me a message that you are beyond gifted. Well, doctors, you know, in the world, you don't know when you meet someone who really has your interest at heart, right? Yes, you can come into my program and I'll be very glad that you come. But even for those who are not in my program, I hope these sessions have been helpful. Okay, I hope these sessions have been helpful. So thank you very much. Don't forget, I'm going to drop the link to the registration for the QA1 class. You can even decide to take just a 1 month access, just 1 month access, especially if your exam is coming up, or you go like, this Dr. Bruni guy, I want to really be sure about him. Okay, doctor, you can just take a 1 month access. In the 1 month, you still have access to everything in MedCognito, everything, all the videos we recorded, everything. And then you can attend all the live classes during that 1 month. And then you will judge for yourself, okay, whether MedCognito has your interest at heart or not. And it is only somebody who is very sure about what he's given who can be this bold to say these things I say. Okay, so just imagine this is a free class. What happens in our actual live classes, right? So doctors, thank you very much for spending your time with me. I'm putting the link in the comment section. Don't forget that my phone number is +1 306 891 5649. +1 306 891 5649. I'm sharing the link to the registration as well. Can come in for the 6 months, $420 every month. One-time payment of $2,199. Whichever one you prefer. Whichever one you prefer. Whichever one you prefer. Okay? Thank you very much, doctors. And don't hesitate, I'm your friend. You know, reach out. You have any question, reach out. Reach out to me on WhatsApp. I prefer WhatsApp because then you can reach out to me from all over the world, right? So far as you have internet. So doctors, remember, I love you. I want to see the best for you. Reach out. Let's make sure that your exam preparation is smooth. Don't forget to spend time with the loved ones you have, okay? And don't forget to take care of yourself. Good day. Enjoy your time. And for the MedCognito students, it's now 4 p.m. EST. Don't forget you have a class tonight. And for those who want to also join tonight's class, you can just register and then you'll be ushered into the class. Thank you very much. Have a wonderful day. Bye-bye.